Hi everyone, I'm Felicia. I'm here to talk to you about 4 different topics on women experiencing OB emergencies. Our first topic today, I did try to make little charts as they were requested, but it's old school, but it helped. First topic today is umbilical cord prolapse. What is it? What's going on here? What are the signs and symptoms? What's happened to mom? What's happened to baby? Well, umbilical cord prolapse is when the presenting part does not fully occupy the pelvic inlet, and prolapse is more likely to occur. So basically, here's a mama, baby's right here, getting ready to push out, but the cord, let's see if I can do this, is coming out first, right? It's kind of pinched and it's ahead of the baby, and it kind of closes it completely, blocking off all circulation to the fetus or partially. Either way, it's no bueno. It's not good for mom. It's not good for baby, especially for the baby. Sometimes this happens when the umbilical cord is within the uterus, or when the cord is, you can see it visually in the vulva before it's expelled out. So the first sign that we can expect to see is sudden fetal bradycardia. So the heart rate of the infant, the fetus, is going down quickly. Or a recurrent variable of decelerations that become progressively more severe. We just learned this today. I need to read up on that, but it is kind of interesting. And I imagine on what we saw today, you can kind of see the decelerations of the fetal heart going down. Again, no bueno. We want to get control of this right away. Call for help ASAP. We want to save this baby. Okay, don't leave mom alone. All right, you want to keep her calm. You've got to keep yourself calm, but you want to get help like ASAP. This is bad, 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 bad. This can cause fetal hypoxia, which can lead to, so this decreases the oxygen to the infant because the cord, which is attached to the placenta, which is attached to mom, can be depleted very rapidly, which can cause fetal death. What we're going to look for, to see if the cord, if you see the cord, obviously you know it's not good. But prolapse cord, if you see it, you want to reduce the risk of the fetal hypoxia. So you want to assess mom, okay? Check on mom. You want to see, all right, how's mom's breathing, okay? Monitor the heart rate of the infant as well. Give her oxygen if we need to. You want to assess mom and her history to see what could possibly lead to this, such as growth restriction, prematurity, ruptured membranes with the fetus at high station, or hydroamnios, which is excessive amniotic fluid. We want to continuously assess the fetal heart rate, make sure that it doesn't go down any lower than what it already is. You want to make sure the mom's at bed rest and give the oxygen, especially if it's not ordered, give it to her and then get the doctor to order it, okay? Remember your ABCs. This is very important. Management. What are we going to do to manage the umbilical cord prolapse? If the cord is compromised or compressed, we want to have assisted measures to help relieve that pressure. One way of doing this is the examiner, the doctor, or the head nurse who helps, who's right there and sees it, dons on sterile gloves, puts them on, and they go into the vagina, pushing that prolapse cord out of the way to help relieve that pressure and holding it there until mom is ready to deliver this baby. Sometimes we can also help put the mom in a different position to help relieve that pressure by putting her in a modified Sims, have her knees to her chest, or put her in the Trendelenburg position. If the cervix is not fully dilated or effaced, dilated open, effaced thin, we want to prepare for an emergency C-section. Again, the goal here is to save the baby. We don't want the baby to die. We don't want the baby to suffocate. So that is what I have on our first topic. On our second topic, we have placental abruption. What is it? What are we going to do? What are the risk factors? I kind of like to describe this as, so you have your placenta on the uterine wall, right? and a piece of it comes off. Kind of like when when you're a kid and you used to rip off the scab off your arm. Think of it as like ripping off a scab and it's just going to bleed, right? So what is it? It's a premature separation of a normally implanted placenta from the maternal myometrium. This can lead to preterm birth or to prenatal mortality. The risk factors that we really want to pay attention to, again, we do our health history on mom. Does she have a history of preeclampsia during this pregnancy? Gestational hypertension. Does she have a history of seizures? Is mom older than 34 years old? Uterine rupture, uterine trauma, domestic violence, which also could lead to that uterine trauma. Did she fall down some stairs? Did she fall off the sidewalk? Cocaine use, smoking, premature rupture of membranes, a previous history of abruption, hydroamnios, again, the excess of amniotic fluid, and coagulation defects. All of these risk factors can force the blood, force that separation, either full separation or partial, forcing blood into the underlayer of the placenta, causing the detachment. Again, that is the placenta is the life force for the fetus, so we want to make sure we keep it in there. So our treatment, what are we going to do? Well, we're going to determine the severity of the hemorrhage, how much is mom bleeding, the gestation of the age, where is she at in her pregnancy, and we're going to monitor mom and baby's oxygen perfusion, and we're going to reserve that status. We want to maintain cardiovascular status of mom and fetus and try to develop some type of plan very quickly to get this baby delivered ASAP. Very, very quickly, very important. This could be by C-section, but if the she can have a vaginal delivery if the fetal demise is secondary to a complete abruption. So either way, little side note, I had this with my son 23 years ago, and it was due to some uterine trauma and domestic violence. So it is not fun. You do bleed a lot. It's very scary when you're 19 years old and you're like, what the heck's going on? But he made it through, and he's a big boy now. All right, topic 3. This is a catastrophic event. This is no bueno. This is the uterine rupture, okay? Not good. The more I kept reading about these, especially this one and the next one, it's kind of scary. What could potentially happen to mom and baby through all the organized chaos of everything in labor and delivery. It's pretty terrifying. So uterine rupture, it's very rare. This is a high risk of fetal anoxia or death. So I kind of related this to excessive amount of blood around the baby. So anoxia, I take it as the baby's drowning in blood, essentially. I know that sounds awful. It's horrible, but this is what was going through my head when I read up on this. So what is it? Uterine rupture is the tearing of the uterus at the site of a previous scar into the abdominal cavity. This leads to massive amounts of blood, causing the fetus to drown, essentially, the fetal anoxia, or to cause that catastrophic hemorrhaging, or it could lead to both. It's very sad and terrifying experience. I can't even imagine. Time is of the essence here. You want to get mom prepared for a urgent cesarean. You want to remain calm. You want to get the team there and get it started right away. The signs and symptoms are usually difficult to predict, and it's also difficult to prevent as well. It's usually the first thing we're going to notice is sudden fetal distress. Again, monitor that fetal heart rate. Is it not moving anymore? What's going on with this baby? We want to help this baby. We don't want to make mom freaked out. Mom, is she having acute and continuous abdominal pain? Even if she's on the epidural, she could still have the cramping and continuous abdominal pain. You're not supposed to feel anything. That's not normal. Is she having severe vaginal bleeding, hematuria, irregular abdominal wall contour? Is there loss of sensation in fetal presentation? It's there, we're going to see it, and then what happened? And hypovolemic shock in mom or baby or both. Again, not good. This is a bad situation. We want to continuously monitor the vital signs on mom and baby. We want to observe for hypotension, tachycardia, which can equal to and cause the hypovolemic shock. With the excessive bleeding during childbirth and persistent signs such as bruising or petechiae appear, this could be an underlying cause of DIC or disseminated intravascular coagulation. Again, no bueno. So whenever we see mom, we want to review mom's history. Mom's history is always going to be key on everything. The risk factors can be, has she had a previous C-section or uterine scars from a different surgery, prior rupture, trauma, poor invasive molar pregnancy. Remember that's, I kind of like take that as that fake pregnancy. History of placenta, bear with me, percreta or increta, and congenital uterine abnormalities and cocaine use. So these are the things we want to make sure that mom doesn't have. Again, when mom first finds out she's pregnant, it's very important to know her background so we can hopefully potentially prevent these issues from happening. Our fourth and final topic, again, another very, very scary one, is amniotic fluid embolism. Not good. Also equally as terrifying as that last catastrophic event. This one's even more catastrophic. More to the father and the family of mom and baby, because the survival rate for mom is less than 60%. Like this is not good. All right, like these moms die. Okay, this is not good. As many 50% of women die within the first hour of onset of symptoms. So again, act rapidly, act quickly. Only 85% of women who survive this have a long term of hypoxia-induced neurologic damage. This is just a bad thing. What is amniotic fluid embolism? This is when an embolus occurs to the barrier between the maternal circulation and the amniotic fluid, and it's broken. The amniotic fluids burst, and all of that stuff that's protecting the baby, the skin, the baby's hair, that verinix, that covers the body, even the meconium, basically the fetus poo, all that goes into mama's system, okay? And it goes through her venous system and to the endocervical veins and the placental site, if the placental site's separate, or into the site of the uterine, causing trauma. So these particles and this debris enters mom's circulation, causing obstruction of the pulmonary vessels, which equals respiratory distress and circulatory collapse. This is bad, 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 bad news, okay? Mom she's hanging on to time, okay? Time is very important here. This leads to respiratory distress, cardiac arrest, signs and symptoms, difficulty breathing, hypotension, cyanosis, mom is turning blue, hypoxia or hypoxemia, uterine atony, seizures, tachycardia, coagulation failures, and that DIC, that disseminated intravascular coagulation, and possibly pulmonary edema. What are we going to do? How are we going to do this once we notice this? Okay, we've got, what did it say? Mom dies within the first hour? Okay, resuscitation. Get mom on oxygen 100%, okay? We want to get that team in there right away. We want to put IV fluids in mom, the inotropic agents to maintain cardiac output and to keep her blood pressure where we need it. We want to control any hemorrhaging and coagulations. put mom on any seizure precautions, making sure she's not going to seize out on us. We want to monitor her pulse ox, her skin color, her temperature, and quite possibly we might even give her the packed red blood cells to keep everything going. We want to keep mom happy. Again, very, very scary experience. And if mom dies, like, it's a very difficult thing to explain to the parents of the mother, the family, what happened. So you have to be very calm and know, the outcomes of what happened, what you tried to do, and know there's going to be some resentment from that family. So this is what I learned today on these 4 different emergency OB terrifying experiences. I've only had to experience one, and it was nowhere near like the last 2, but still very terrifying as well. That's what I learned. Have a good weekend.